with our very first Cassini seminar. This is fun. Webinar, there we go. At any rate, I am Mark Mayer. I'm the CEO of Cassini Technologies. Thank you all for joining us. With me, welcome Dr. Wiley and Dr. Stephenson. Thank you both very much for being here. Please, Dr. Stephenson, tell us a little bit about yourself so the folks, I can't imagine anybody doesn't know you, but for anybody who doesn't.
Well, I'm Dee Stephenson, and I'm in Venice, Florida, and I have a boutique practice. About 92% of my cases are premiums, and loving Cassini, have for a long time, and of course, my hero, Bill Wiley.
Dr. Wiley?
Thanks, Dee. Well, you're my hero as well. I learned so much from you, and look forward to this webinar tonight. I'm Bill Wiley, Medical Director of Cleveland Eye Clinic here in Cleveland, Ohio, and perform cataract and refractive surgery. I've always had a thing for guidance, and there's been a lot of cool tools that have been out there to kind of guide us when we're in the OR to, put the lenses in the right spot. And it's cool to be working with Cassini on this new tech. So thanks, Mark, for pulling us in on this.
You bet. And thank you, Dr. Stephenson and Dr. Wiley, for being some of our early users and helping us get this launched. For those of you who are not familiar, Cassini is a topographer. We use ray tracing technology. So there's 700 LEDs that blanket the cornea to get really great measurements of both the anterior and posterior cornea. That data with our guidance system, now all of the data from the clinic, and it can even be your other devices in the clinic. So your other diagnostics, whether it be your biometers, your other topographers, whatever it is, all of that information goes into the planner, and the planner is cloud accessible. So patients go through the normal flow. All of the data is uploaded from the Cassini in and populates, so we don't run into any transcription errors there. And then the doctors can simply go in, validate all the information on the patient, and when they've got the right lens, and we put in all of the lenses. I know, Dr. Stephenson, you're using a lot of B&L lenses, and Bill, I've been with you, and you use, my goodness, just like about everybody else's lens. But we've got all the lenses in there. And if you need to add some lenses, we can always do that. But the data then is in the planner, and then the planner is the data from the planner is either sent via the network. In the case of Dr. Wiley, it just works right directly from your network, right into the operating room to the guidance. And then with Dr. Stephenson, while the Cassini is running your LENSAR, we also are on the front end of the LENSAR laser, but then that data can also go over via a USB if you don't have a network that runs to your operating rooms. Once you're in the OR, we've got a big 32-inch screen that is there, and fairly simple to be able to do the registration. We were talking about this the other day. And Dr. Wiley, your experience on the registration portion of that?
Sure. Yeah. I mean, the registration's seamless. Basically when I'm getting the eye set up at the very beginning, putting the lid speculum in, lubricating the eye, the scrub tech can either, or the circulator can register at that point. As soon as they see there's a clear window, they can register. Or also, and we'll talk more about this, but I'm still doing sort of a belt and suspenders. I've been using Cassini kind of head to head with Aura, and using both sort of preoperative information to kind of help guide me, but also intraoperative information. And there's a point at Aura when we first kind of set up, and I had the patient look at the light, and my circulator just basically runs both machines, captures Cassini, takes maybe 3 seconds, and I think Aura takes maybe 10 seconds, I'm not sure, something like that, to do the capture. But in that point, we're capturing with both devices, and then I can compare the results, and it's pretty cool. So I can see, so what was the preoperative information, how is that guiding us, and then also intraoperative information, and see how those correlate.
Perfect. So and then Dee, in your experience, because you've been using the Cassini with the LENSAR laser, what have you been finding with the guidance versus what we've been doing with the Cassini running the LENSAR?
Well, I do everything that Bill does, and we've been Aura users since day one when it was orange. So, I always want to, I still go back to Aura for my final reading, but when they all line up, it's amazing, and it's where I want it to be. But the nice part about having Cassini with my LENSAR is it makes the antelli-axis marks, and this correlates to what's on the Cassini guidance, and I find that it's really pretty much exactly the same with the guidance itself. So it again, it's a belt and suspenders as well, but it also is just confirmatory, and for me, confirmatory makes my job so much easier, and I feel very comfortable leaving the OR with the patient having 2 or 3 things all match. So it's kind of where I am.
That's terrific. We did get some questions that have come in, and we got some earlier questions, so we'll just start with this. And will it work with any microscope? Dr. Wiley, you've got an older Leicoscope?
Yes. So we've got an older scope that we've been using it on. We have one of the early scopes. Gosh, I've been in practice over 20 years, and it was a scope that we had, apparently the surgery center had bought, used at that time. So it's been following around for some time. And it's interesting. We just keep upgrading it with new tech. And, we upgraded it with, True Vision. Mark, you helped me, integrate that back in the day. And then with Aura, and now we've got Cassini. So we've got some really cool, upgraded things. But what's nice is, there are, there as everyone knows, there's other guidance systems out there, but it can be a big commitment if you're going to have to buy a whole new scope and new diagnostic and integrate that, and then let alone put it in multiple rooms. And so what's great is this can be literally put on any scope, from something over 20 years old to something that's brand new. And so it's a great add-on for any scope that's out there.
And I have a Zeiss Lumera Eye, which is an older Zeiss machine as well. And again, since Cassini is agnostic, or Switzerland, however you want to look at it,
Sure.
You can have any microscope, and it's nice. And same with Aura for that matter.
Yep.
And you have to have an Alcon machine.
Right. Yep. And we've got it on Alcon scopes, and I know that we've got it on some of the newer Zeiss scopes. And then the only one that we're still waiting on is the brand new Leica Preveo, because they have an internal beam splitter and camera system. And so the way that our system works, as you both know, is that it's just a standard beam splitter that's got the 2D camera on the side. So we just get a good high definition or 4K camera that's capturing that image and going directly to the guidance system. So we're not really adding anything new to the stack. This is the same beam splitter that we've used forever, really.
Right.
Yep. Okay. Data transfer. We talked a little bit about that. Either using the network. Dr. Wiley, I know in your clinic's on the other side of the wall.
Right.
And Dr. Stephenson, you're going across the street, I believe, to your
down the street.
ASP. Yep. So whether it's a USB or being able to send the information in via your network, it works great. And I see that we've got another question that came in from Dr. Mack. Hi, Ivan. Hope you're wonderful. Asking about how this works from like the smart cataract from Alcon. It is different than that, Dr. Mack. The data is we allow for all of the diagnostic data from the clinic to go into the planner. It's cloud-based planner. And that allows for you to be able to access it from anywhere. And then it works with any microscope that is out there, as well as any of the lenses that you want to be using. We can populate the planner with any lens, and then you can put in any of the formulas that you are comfortable using, whether that's Baird or Holiday or Vegas or HRT or whatever they have.
Up to 4, right, Mark? Right
Yes,
now,
ma'am. Exactly. And so I think that that's makes it a little bit easier. And then there's from my experience with the because I sold True Vision to Alcon and spent some time there. My experience is that this is a lot easier and faster. And we were talking about that just a few minutes ago, where Dr. Wiley was saying it takes about 3 seconds to register the image, and you've got it there, and all of the data is on the screen. So based on where you make your incisions, we have your incision points there. We account for cyclotorsion and show you exactly how much cyclotorsion you've gotten, show you exactly where the capsulotomy is so that you can follow your capsulotomy if you're not using a laser. And then we show you where the center either of the optical axis or the visual axis, depending upon how you want it set up. And this can be a per patient, or if you always like it on the visual axis, we can go that route as well. So I think those are some of the things that are perhaps slightly different than the Smart Suite. Yes, Dr. Wiley.
Yeah, and I think you've got, let's say, the Smart Suite from Alcon. You've got Zeiss, Veracity, and those are great systems and great diagnostics. And and right now I probably use more Alcon stuff. We have an Argos, but we also have a Zeiss IOL Master, and both really nice biometers. But what I feel like is lacking from the other systems is that foundational piece as far as preoperative posterior corneal astigmatism is hard to measure. And as much as Zeiss has it on their readouts, I haven't trusted it a whole lot. I think it's a piece of information, but I haven't leaned heavy on that. I tended to lean more on intraoperative information for posterior corneal astigmatism. The Argos, I don't think has a posterior corneal astigmatism tool with it. I'm not sure, Dee, if you know or not, or Mark.
I don't think it does.
Yeah, so that foundational piece is great. It's a great biometer, but it's missing that piece. And I think what's great. So even if you're using those other tools, you probably, if you want to have preoperative diagnostic that's going to help guide you, I think it really is important to have something that can measure the posterior corneal astigmatism. And from what I can tell, Cassini is doing that better than anybody at this point. It's a cool area. And I think, Dee, for you and I to kind of move on from Aura, I think we're going to need a great diagnostic. And I've not seen anything, compare yet. Now, granted, Aura is complicated. You got to have all your variables perfectly aligned, and it can be challenging. What's nice about this or any preoperative diagnostic, you don't have to, weigh as much intraoperative. And if you can gather the same information preoperative and be confident in it, I think it's going to be a big step forwould. So now
in preoperative, I mean, that's the holy grail. If you can get it all preoperatively, then, it would make the rest of it a lot easier. So
Right. And so right now we're doing an analysis. We're going to present it at ASCRS, but we're looking at around 50 eyes that are measured with both preoperative and intraoperative. And I can say anecdotally, I've been impressed of what I've seen so far, and it looks like it's head to head, or hopefully I would say that hopefully it'll pull ahead of even Aura, because there are some variables that are just hard to predict sometimes intraoperatively.
The other thing too, I think is important is that, and Cassini is like within 3 degrees, plus or minus 3 degrees, whereas other things are like, if you're 10 plus, and it's like, that's a mistake if it's 10 plus.
Right.
And because you don't, again, Bill, you and I are spoiled rotten because we have not marked a cornea in since the early days of Orange. We have not marked a cornea, or I have not marked a cornea. And I mean, heck, I don't know how long it would take me, 5 minutes to do it, and I know that Mark Packer presented Doug Koch's study at a ASCRS in 2023, and I think it was 5.5 minutes to mark the cornea. Yeah. So it was
that's longer than the cataracts.
Yeah, really.
and that's really it. When we actually I actually walked around with a clipboard and timed one of my surgeons, Greg Hazen, up in Saginaw, Michigan, and he would leave OR1, go out and mark the cornea, and then come back in and go into OR2, and then Same thing over and over again. So as soon as he left the operating room, instead of going back into an OR, I started this stopwatch. 5 minutes and 39 seconds was the actual count that we averaged out to, because as you know, it's just not possible to walk up to a patient, mark their eye, and turn around and walk back in again. You know, the spouse is asking if they can do dishes later that day, you know, how much, you know, it's the whole conversation. How was your weekend? And so there just isn't any way to just keep things moving along. And I know that both of you, since I've been in surgery with you, just keep cooking right along because you're not doing that. But for people who are trying to get into doing premium, I know that there's a lot of wasted time, and that is the most expensive time is in the operating room.
And go ahead.
I was gonna say, I never much thought about the time expense, but it's interesting you say that. But just the accuracy. I mean, those marks, the big ink mark is just so inaccurate. I mean, that's like
it bleeds 5 degrees.
Right. And so, that's always worried me. Like, I mean, the digital marking is so cool just to see, the digital.
Oh, and even, you know, scleral vessels. And then it, for instance, you know, you grab the eye to rotate it a little bit, you just cause a subconjunctival hemorrhage, and now you can't see the scleral vessels. So, you know, it's, I mean, I'm very spoiled. If I had to mark, I'm not sure what I would do. You know, I also too, I do surgery at 12 o'clock. So my incision from LENSAR is always at 90 degrees. So I have a mark, you know, after the LENSAR, but, and I always align my aura at 90, but, you know, it's still, those are, you know, seconds, not minutes.
Yep.
Right.
Yep. I know that we've got an image injection unit that is coming, so that you'll never either have to look away from the Ingenuity system that you're using, Dr. Wiley, or away from the oculars, Dr. Stephenson. But currently, because it's on the big monitor, have you found that to be an interruption to your workflow at all, just in the current setup?
Yeah, sort of yes and no. I think it's interesting. It's now becoming a true cockpit that I'm in. I've got the Ingenuity screen for 3D. I've got an Aura screen over here, and I've got now this new screen. So I've got 3 televisions that I'm looking at and doing surgery. So there's something that's kind of cool about that, but it is a little annoying kind of looking back and forth. You're looking at the TV, I'm looking at the Ingenuity, and then the Cassini alignment, and it's back and forth. Initially, I didn't think much about it because I'm doing heads up anyways. I'm already heads up. I'm just now scanning back and forth. But I can imagine if you're looking through a scope and looking up and then looking down, that could be, I don't know.
For me, it doesn't, once I've gotten used to it, because I even though I have Aura in my ocular, I still look at the screen because it tends to tell me a little, like the screen, because it gives me three things to look at. And when I'm looking at that, I'm just looking at the graph, if you will, of the patient, looking at the center of that. I'd rather look at the screen because I'm looking at 3 separate entities. And then I can also look at a 4th thing, which is across the top, which tells me the refraction. So those are all important things to me. So it really hasn't been a problem for me looking at it, but I can't wait till everything's in the oculars and it's all, just perfect for me.
Right.
Yeah. And in the case of our Ingenuity users out there and Dr. Wiley, with that image injection unit, then it's just simply going to be overlaid right onto the live eye on the Ingenuity. So that'll work out. That'll work out great. But right now, you're going to stick with that fancy cockpit that you have for a short period of time. Let's see, what other ones do we have here? Toric lenses. Dr. Wiley, you're using a number of different toric lenses. How many different lenses types are you using, and what's your experience been?
Yeah, I mean, thus far it's been great to help zero in on the toricity. It's done a great job of measuring that posterior corneal astigmatism, and so it gives me confidence that we're putting the lens in the right spot. Nowadays, I tend to, anybody that we can put in a toric, we tend to lean that way. And so now you have presbyopic. I mean, you have a trifocal toric, you have an EDOF toric, you have a standard torque, and then you can even have other ones, one that you'd use for hyperope, or non-aspheric, and all these different torque lenses, and it's seamless to have that in the planner and have that ability to choose whatever you think is going to be appropriate for this case, and it helps make that plan for you. So it's sort of makes it a non-issue.
Great. Dr. Stephenson, on the planning side,
Yes.
And going through the data on the planner, what's your experience been? I know that you've used some of the other planners that are out there, as well as ours. What's your experience been?
Well, I will say this: the veracity of the Zeiss. I have to reboot for it to pick up the IOLMaster 700 which is their product. So I'm very frustrated with that. This is just pretty much straightforward. I'm also early in use for the new B&L one. Beside that, I cannot give you a comment about, because I don't have enough experience to give you my opinion. But I think it's pretty straightforward. I figured out, it's got my lenses in it. It's just a click. It's just a click. It's all packaged in there. So you just click a button. And the nice part is there's two parts to it too, because when you go to the operating room, you've got the patient's name, a picture of the patient, their allergies, their medications, if they've had RK, whatever information you want to put in there is what comes up on the screen before you take the registration. So it's really nice to review, because I used to be able to remember all my patients, their names and their eyes, the eye we're doing. And the older I get, it's a little bit harder. So I do like the fact that it says Joe Smith, and there's a picture of Joe Smith, and I can say, hey, if it's taking us a little more time, I know Joe Smith, so I can say, hey, if I write something about how's your new great grandson or something, so we can pass the time, so it doesn't seem like it bothers the patient too long to have 2 or 3 minutes go by before we can do a registration if there's something else going on in the room. So I find it really nice. And then, of course, when the screen comes up for me to take an image, the nice part about that is that follows the case throughout the whole, it shows the case throughout the whole time, so that you're able to review it if you want, because you can have a video and look at it, or you can take a still shot. So it's kind of cool from that standpoint, because if you find something that's not correct, not similar, that your belt and suspenders is falling apart, you can go back and look at your acquisition and make sure that it's a good acquisition. I mean, it won't register if it's not. It'll register, if it's red, or it won't function, or it's a kind of an orange or a yellow as a warning, or it's a green. So you really can tell whether you've got a good acquisition or not. So I think those are good little pearls that are already in the acquisition screen. And then you see the steep axis, and it's marked. I mean, it's marked with the lines, and as your eye moves, those move with it, and it's pretty straightforward. So, and it's nice. It follows your eye throughout the case. So it's a good screen to look at. But it's nice, and it's very foolproof. If you got a problem, then you ask a question, and then it's fixed. Yep. So.
Nice. And that was something that I thought that the developers did a great job on. Well, this was a lot easier to use than some of the other systems that I've seen out there in the 30 years that I've been in ophthalmology. And so, but what was a clever idea was being able to send all that timeout information. I mean, we have all the patient data. It's all there. It's all, so why not say, this is Mrs. Smith. We're doing her left eye. This is the lens that we've selected for. This is what the residual astigmatism is going to be based on that lens. I mean, everything is right there on the screen, so the staff can verify that, it's essentially the timeout screen, that they can see all of that. So I thought that was really very cool. Dr. Wiley, you and I are working on some studies that we're going to do at ASCRS. It's showing residual astigmatism and the ability to planned for that? I'm missing a word here. Can you help me out a little bit on what we've been doing in that study and how you've been seeing it in the operating room?
Yeah. So yeah, basically we're looking to see, out of all our diagnostics, what is the most predictive for that residual astigmatism? So if you have Cassini with its total corneal astigmatism, you have eyewall master. We also have pentacam, and then we have intraoperative aphakic refraction with aura, and then pseudophakic refraction. So we have a number of different points that we're collecting this information. And the question is, what's the most predictive for that 1 month refraction, and what are you going to lean on time in and time again? And so and so I'm looking forward to seeing how Cassini stacks up. Thus far, anecdotally, I've been really impressed. And so if we can have this tool that really gives us that piece of information, I think we'll all, it would be a tool that certainly could be repeatable and reproducible across a wide range of surgeons and patients and situations. So I'm hoping that that's going to be the case, and look forward to presenting that.
That's great.
Look forward to hearing about it.
Yeah. Well, our plan, and I think I'm fairly confident in this, is that we're going to be able to, because you're very consistent with your incisions, and with us being able to show, in that range where you're comfortable, where you're going to be making your phaco incision and your paracentesis, and then being able to have that be consistent, so that with your surgically induced astigmatism, we can really plan for what that residual astigmatism is going to be post-operatively. We can start to really rifle this in and make certain that what you are telling the patient you're going to get as an outcome is in fact what you're going to get. It's very simple for the staff to be able to use in the OR. It's not taking any time away from them being able to care for the patients. And the accuracy that we've seen so far has just been terrific. So cool. I'm looking forward to getting that data presented too. But I like where this has all been going, and both of you have been so great in helping us do the development on this. It's been really wonderful.
Cool.
Dee, anything else?
Well, the two things that I think that have made it really helpful for me, again, is the fact that I can actually see all of it on that screen. Where my incision is, where my paracentesis is. I would love to get the LRI on there as well, but like Bill, if I can put a torque in a patient, I'd rather put a torque in than cut the cornea. That's just me.
Right.
That and the fact that it's so easy to get the acquisition. I mean, literally seconds, and what the quality of the acquisition is. Those are two things I think are really beneficial to me as a surgeon. And, again, I'm a creature of habit, and my incision, like Bill's, is in the same place. I put it in the same place. I don't float my incision anywhere. It's always at my surgical incision is at 90, and my paracentesis, depending on which eye, is 30 or whatever. And so that makes the variables less, and it's just really nice to be able to see it. And I can't, it'll be great when it's in the ocular, when it's overlaid on whatever system somebody might already have, if you have the heads up or whatever. So I think it's I don't think there's a large learning curve, and that's the other beauty. So there are three things: the acquisition, the repeat of where your incisions are, and then to be able to look at it the same way every time. So I'm so it's easy. There's just no learning curve to this. I mean, in the acquisition now, to perfect it, there's a learning curve, because you have to be able to decide what you're going to use. So but to use it itself there's no learning curve. Right. But to understand it is a little bit more of a learning curve.
Yep. Dr. Wiley, anything else?
I think we've covered so much. It is a great tool, and really excited to continue to pioneer and work with you on this great tech. One thing that does come to mind, I was thinking about, Cassini's been around for a bit, and we had our original unit. Gosh, it's been easy, maybe 10 years. But I will say that this newest unit is a step forward. I don't know all the ins and outs of how it's different than when we first got in, but I know when we first got in, good tool, but it's a little bright, a little hard for the text to work with it, and a little hard to capture. And so I do want to say that if anybody's tried Cassini in the past, this is definitely new, and it's an upgraded version of what's out there. And so that's a good news, but it also tells you they've been at this for some time. This is not their first rodeo. They understand it. They're motivated to figure out. And I look at, this diagnostic, with all the data points that it's getting is way different than some of the other diagnostics. If you look at, let's say, IOL Master or Argos, I mean, great tools, but if you look at, aligning a toric lens off some of those tools, it's not quite the same as that when you look at the amount of data, both front part of the eye and back part of the eye, to gather that information and then analyze it and then project that into the operating room so that we're going to put the lens in the right spot. So there's so many pieces to that puzzle to make sure it all stacks up right. But number one, you've got to capture. Number two, you've got to then register in the operating room. And number three, you've got to be confident you can place it based on that. And so I think Cassini's checking all those boxes. So great work.
And I'll have to add, Cassini Ambient used in the office as a diagnostic tool. There's so much more to that machine than people realize. I'm a big dry eye person, and all of us, if we're not dry eye people, when we're cataract surgeons, we need to be. And, the nice little grid pattern, the honeycomb pattern that it shows. Yes. I mean, yes, you can look at the LEDs and see which ones are blurred, but when you're looking at the central part, if you can see the honeycomb is nice and clear, and it's perfectly symmetrical, then you know that the cornea is not dry. It also has a video capability where you can actually see the patient's blink. You can see how the tear film actually flows over the cornea. You can see where they're lacking in a tear film, if they have dry spots, if they have matte dot dystrophy, if they have something that's disrupting their tear film, even conjunctival chalasis where they blink and it's all smeared along the inferior, or if they have RK and you can see the spots on where the RK incision is, or previous penetrating keratoplasty, or even LASIK where you can see that maybe they have some scarring in their flap. So all of those things are very visible on Cassini Ambient. It's easy to get a reading on the patient in the office. Literally, my technician, and I have to give both my techs a shout out for all the hard work that they do. And the one that does most of my surgical stuff is Saray, but it's nothing. It used to take, an hour and 15 minutes to get preoperative stuff. Now it's like 15 minutes to get 4 or 5 different machines. And Cassini is really the first one that I look at and pay attention to because of the corneal surface indicators on there. I have other machines that do it as well. And you can look at the Purkinje images on an IOL Master, and I'm sure on LENSAR and on the Argos too, to tell you, but not like the profile that the Cassini Ambient has with the videos and the honeycomb pattern. That's just, those are just no-brainers. And you can show them to a patient and you can say, look at this honeycomb pattern. It's supposed to look like this. And look when you blink, or if I put an artificial tear in the patient's eye and then do it, you can really show them the improvement. So telling them to use a drop is one thing, but showing them what the drops will do, or the lid hygiene, or the, whatever, using a cyclosporin for a time being, and repeating their preoperative evaluation, because repeatable results gives you repeatable outcomes. And if you don't have a good, if your cornea is not good, garbage in, garbage out. You can't get a good ambient reading. You're not going to get a good IOL Master or A-scan reading, and you're not going to get a good outcome. And you're going to pick a lens, and you're going to pick a toricity of a lens, and you're going to be way off, or you're going to miss the axis. So I really think that there's a lot more. There's a big, this has got a lot breadth and depth of information. that Cassini has, not just in the operating room, but before you ever get there. So I think those are, if you haven't looked at the Cassini Ambient for your office, before you look at the, our surgical package, you need to look at what the Ambient can do in your office, because I think it's invaluable.
Awesome. Thank you. That's a wonderful plug. I really appreciate it. Thank you both very much. I'd like to thank everybody who joined us tonight. I'm super grateful, and hopefully got a chance to talk to people or share how the Cassini connected OR works. Any microscope, easy to use, super fast and simple, and extremely accurate. And I'm grateful to both Dr. Wiley and Dr. Stephenson again for all of your time and for working so closely with the company. We're grateful to have you. So.